Hi, everyone. Welcome, and thanks for logging in right on time. We're going to give people a few minutes to get logged in and get settled, and then we'll get started. Thank you. All right, in the interest of maximizing our time together, we're going to go ahead and get started. I'm Sarah Brewer. I'm the director of our education program at Accords, and I want to welcome everybody to our Accords program seminar today. This is a part of our health equity methods and challenges in health equity series. So let's start off with what is Accords. We are supported by the University of Colorado School of Medicine and Children's Hospital, Colorado. Accords is a unique one-stop shop environment for faculty to conduct pragmatic research, receive various types of services and supports for grants and projects, along with incredible mentorship, training, and education in health services research. So Accords conducts pragmatic research in real-world settings to improve healthcare and outcomes by providing a multidisciplinary collaborative research environment, strong methodological cores and programs led by national experts, consultations and team building for grant proposals, mentorship, training, and support for junior faculty, and extensive educational offering both locally and nationally, of which this seminar series is one of our ongoing programmatic offerings. In addition to this seminar, as part of our methods and challenges in conducting health equity research, in April, we have two seminars coming up. The first is part of our Hot Topics in Mixed Methods and Qualitative Research, and today's actually sort of overlaps with that series a little bit. But we'll have Dr. Rupali LeMay from Johns Hopkins talking about longitudinal qualitative data and cross-sectional quantitative data. Another nice mixed methods example. And then at the end of April, April 24th, we'll have Dr. Elisa Khan from Boston's Children and Harvard presenting on promoting language equity in research. In May, again, as part of our mixed methods and qualitative research series, we have Dr. Jody Summers-Holtrip talking about complex mixed methods designs. And mark your calendars and register now for CopperCon, our Colorado Pragmatic Research in Health Conference, June 5th and 6th. We are primarily in person, and we hope you all will join us in person for our theme around reassessing evidence for real-world research and practice. All right, but today we are here to hear from Dr. Margarita Alegria on using mixed methods to understand nuance in disparities work, Photovoice and Medicaid studies. Dr. Margarita Alegria is the chief of the Disparities Research Unit at Massachusetts General Hospital and the Mongan Institute. The Harry Leonard Jr. and Lucille F. Sear Leonard, endowed chair at the Mass General Research Institute, and a professor in the departments of medicine and psychiatry at Harvard Medical School, the Mongan Institute. She spent her career examining how to reduce health disparities for populations of color, immigrants, and linguistic minorities. Dr. Alegria is currently the PI of 3 National Institutes of Health-funded research studies and is also PI of a Robert Wood Johnson grant assessing opportunities to establish institutional policy and systemic changes to increase racial and ethnic diversity in academic health sciences. She's published over 300 papers, editorials, intervention training manuals, and several book chapters. She's received notable awards, including most recently the 2022 Inclusive Voices Award by the American Association for Public Opinion Research. Please join me in welcoming Dr. Margarita Alegria today as she presents Using Mixed Methods to Understand Nuance and Disparities work, Photovoice and Medicaid studies. Welcome.
Thank you so much. Let me share my screen, and thank you everyone for being here. This is work of a collaborative group, but I'm hoping to talk quite a bit of, what are we seeing? How do we try to get at nuance? Because disparities work is very complex, and typically there are many factors that impinge on what you're actually are the reasons for the disparities that you're observing. So I thought that I would tell you about 2 studies in particular that are very recent and how we dealt with doing mixed methods to really understand what was behind the disparities. I have no conflicts to disclose, and I look forward to getting as many questions as possible. I'm going to start with the 3 learning objectives that they asked me, which was that you will be able to identify 2 actions needed for collaborating with youth on the development of an intervention. Because one, the photo stories intervention, we're really developing an intervention with the youth. The second is to describe one benefit of using Photovoice with youth, so you can really understand the neighborhood problems that youth are confronting. And then lastly, that you'll name one benefit of using mixed methods approaches to outcomes of Medicaid beneficiaries in disparities work. Let me say that I've been doing this work on disparities for a very, very long time. Actually, sometimes I feel too long. And I love the statement that Einstein said, it's not that I'm smart, it's just I stay with the problems for a longer time period. And that's how I feel with this. I think, however, over the last couple of 5 years, I feel we really have to change the paradigm for the next decade, that we've been really concentrating on thinking about the issues at the level of the individual with very little system approaches. And this is where using mixed methods really allows you to try to see, rather than changing the person, what do we have to change in the systems, especially with issues of structural disadvantage, institutional racism, and lack of opportunities, and how do we move outside, especially the area that I touch is mental health and substance abuse and disability prevention. And also I'm very interested in youth. How can we help youth thrive? And then these are things that I think over the course of the work we're doing now, how do we change explanatory models? And to change explanatory models, this is where, thinking about what are the different components that are at the level of the system, at the level of the neighborhood that can have a big impact. So let me start with, I'm very interested in the area of substance treatment and why have we been doing so poorly about substance treatment. So one of the questions we wanted to know is what is happening in substance treatment? If we create performance indicators, can that tell us where are we not doing a good job? And then also if we mix it with qualitative methods of interviews, can we find out what are the services that people need so that they can have an impact in terms of their well-being? This is a study we did in New York with Medicaid data. And what we wanted to do is evaluate the performance of the Medicaid system in substance use disorder services. We wanted to see what health plans, providers, and administrators said about what we could do to improve the service delivery. But first, we needed to know how was it? We needed to see the performance of the system. And so we use a mixed methods to address three particular aims. The first one is we wanted to understand and assess what were the patterns of access, treatment, and outcomes that we saw in the Medicaid population in New York, with opportunities to see how were plans operating, how was the system operating, and providers operating. The second thing is we wanted to do a disparities analysis to see whether when we stratify by race, ethnicity, or gender, or rural, urban, were we able to identify what was happening? And I'm going to present some data to show you what we did. And lastly, we wanted to bring all of these results to policymakers, to clinicians and patients, to try to see if we could, by showing them the data and getting their feedback and getting what could be improved, we could move the needle forward. So let me tell you particularly, because this is a very strange sample that we took. And the sample, because we wanted to make sure that when you're looking at performance metrics in Medicaid across different insurers, that you have a pretty much the same criteria of severity, the same demographics. You wanted to make sure that the insurers don't have different groups. So what we did is we used what's called the auto-assigned sample subset. And the auto-assigned sample subset were people that didn't select an insurer, and at random, Medicaid assigns them one. So this population in a certain way, it's like if you had randomized the people that didn't select their insurer, so that everyone in the different insurer is going to be then similarly in terms of their severity, in terms of their sociodemographics. So that's what we did. You can see here that on average, it was a population quite young, 36 years of age, 47% were female, 26% were white, 46% were Black. Hispanics were combined with other race ethnicity in here because they didn't differentiate them. And we had around 25% overall, and 7.2% were in supplemental income. The other thing is we wanted to create indicators that would cover three particular areas. We wanted to have indicators of treatment access, treatment patterns of care, and treatment outcomes. And so we developed 18 indicators based on this criteria, thinking about what available data did we have in Medicaid claims, what was the supporting evidence for the validity of this performance indicator, and could they be applied to across all types of SUD. We look for to start this process. This was a very labor-intensive process. We looked at what had been done by the American Society of Addiction Medicine to identify SUD performance measurements. And we saw that they had created some indicators, but many of them were not necessarily clearly outlined, and there were very, very few. So we also looked at Hepner and looked at what did they say were good considerations for having quality indicators, that you have to look at the context where the patient is coming, that you have to think about indicators that are going to incentivize change, and that the measures have to work across different health systems. So you really have to think, how do you create those indicators, discussing with other people, like what will work, what will not. And then we wanted to see that these are measures that could be tied to incentives, but we also wanted to think ahead of time that there would not be unintended consequences by people gaming the system to try to get more the incentives, but not do the work. So as I said before, we separated the indicators into those three categories, and we went back to the scientific literature to see what metrics we could identify that would be in HEDIS, for example, but in other indicators and any that Medicaid themselves would have used. To address gaps, because we didn't find that many indicators as we expected. We were quite surprised that for a lot of the things we thought there should be indicators, there were not. And or if there was a name of an indicator, it was not necessarily fleshed out in terms of who would be assigned that indicator and so forth. So we also talked to indicators that clinicians and health professionals would agree on that would work. So as I said, we looked at, the Donabedian's framework to assess, what were the differences in structure that could be thought about in substance use treatment, what were process measures that, could be received either as treatment or as a preventive care, and what outcomes could be thought about for the purposes of this. So we looked at continuation in treatment, readmissions, emergency care, and mortality. At the end, we couldn't get mortality, so we had to use the other. I also really highly recommend this McLean and Adams about good quality measures. And they talk also about 4 criteria that you need to have whenever you're selecting performance indicators for, services. One is that it's an indicator that has importance. People would recognize it as something you should track because it's important. It has to have scientific soundness. And this is an important criteria because if there's no evidence that if you do this indicator, things would get better, why use it? It has to have usability, meaning it can be used, in different settings, as I was saying before, and people would use it because they really recognize its importance and how it leads to better outcomes. And it has to be feasible. If it's an indicator that takes so much time to collect the information, it's probably not going to be feasible. So we really thought about, what are all of these recommended steps that you need to have, and discuss them extensively with different experts to make sure that what we were selecting as indicators will have different outcomes, that people would, respect the conclusions that you do if you collected the data. So what we did is we brought a lot of stakeholders to validate and see if the indicators would work. We had to talk to people from payment. We had to talk to experts in smoking cessation. We had to have people that were experts in opioids, in different types of substances. We also talked with people that had done this type of clinicians doing this type of work. And then we had to review the codes that we would use to identify the services, the treatments, and the medications that were needed for each indicator. And this ended up being quite extensive. We also needed to say what would be the sample where this indicator would apply, the claims data codes that you would need to do, the definitions of the populations. And we also put the references of the literature that we had used in creating the indicator. We reviewed this with experts. And for some, they also recommended additional algorithms that were not included in what we have. And that took us to finalizing these 18 indicators. I'm going to quickly show you these indicators. It's actually in a paper in Health Forum. And there we also have what are the actual algorithms that could be used for each of these 18 indicators. But you can see there treatment access indicators as screening or assessments. This has to do with a diagnosis in a claim, tobacco screening. We also have patterns of care like smoking cessation engagement, or alcohol pharmacotherapy, or monthly expenditures in SUD treatment, or receive of psychosocial services. So this is very much the services people get. And then we have treatment outcomes as rapid readmissions, relapse, treatment continuation, and social connectedness. I want to start by showing you some of the effects, because if you remember, I told you that people were across the insurer companies, they were randomized. So people should be comparable across the groups. And we tested that and found that they were. So if you see here, there are 9 insurance companies in Medicaid in New York that we had data for in Medicaid claims. And what we did is we tried looking at what were the groups that were doing better or worse from the average across all groups. And we identified that there were only 8 criteria of the performance indicators where some companies were doing, where some insurers were doing better than others. And we definitely can't say which insurers there are, but the state could identify which were the insurers that were doing either better or worse. And you can see there, some companies were doing better for identifying people with SUD. Other people were doing better for identifying people with tobacco to try to engage them. We saw differences in expenditures. But overall, what I want to tell you what we found, and this is a JAMA forum, which is for policymakers, is that there were differences in some indicators, as I said, 8 out of the 18. But what we found is overall, there was not as much differences across the insurers as we had expected. There were a few significant differences in plan mean plan performance, but pretty much everyone, I have to say, most of the plans were not doing very well. They were pretty much, it was across the board, but not doing as much on this performance, which are 18 performance indicators that you would think are needed for getting good quality care. So overall, this told us that the differences across plans was not what we would have expected, that there was limited variation, and therefore we needed something at a higher level. We looked then at racial ethnic disparities in Medicaid managed care in New York City. And what we found, as you would think here, is that we found that compared to white enrollees, Black enrollees were significantly more likely to receive some psychosocial treatments, while Asians and Hispanic other enrollees were less likely to receive it. So we did find some disparities. Overall, you can see here, Black, Asians, and Hispanic other enrollees were less likely than whites to receive treatment engagement and follow-up after withdrawal. So one of the things that really made a very important difference, and we actually just submitted a revise and resubmit about this, was the engagement with the population. And for minoritized group, the engagement to get in care was a lot less than we saw. We also saw that Asian and other Hispanic enrollees received better treatment continuation compared to Black and white enrollees. So this is in terms of continuation. Once in care, we found that these groups, actually Asian and other and Hispanics, were getting more once they are in compared to Black and whites. But we found, what was really, really interesting is we found no evidence that the plan itself could be the reason explaining these differences. We found very limited differences by zip code, by geography, which we thought would be the other explanatory variable that could explain why people were getting more and others less. I'm not going to go into here, but you can see if you go to the last columns, the disparity, the plan mediation, and the place mediation, and you can see there that There were differences in terms of disparities, as we were saying before, but almost nothing could be attributed to either the plan, when we added the plan, or to the place, except we found some effect for Asian groups, where we did find that where they live, certain areas of where they live had to do with them getting certain treatments and not others. So we went into then doing more about really talking about these results, presenting the results to policy leaders. We had 13 policy leaders, to plan administrators, 5, to patients, and to clinicians, which we had 12, and you can see the demographics of the people interviewed. And these people were fantastic. People were incredibly generous in sharing with us, what they thought, could be a difference. And we had estimated that we would be able to interview around 40 people. We started with 7 policy leaders, who then refers to administrators, who then refers to patients. And we also had identified patients through state-listed SUD treatment sites and harm reduction sites. And we did, a very purposeful sampling, because we wanted to have information-rich stakeholders. So overall, we really had this very wonderful group of people that were willing to spend time in a semi-structured, in-depth interview. And this interview guide, really allowed us for quite a bit of being flexible in the interview, depending on the stakeholder, asking additional questions and eliciting new topics. And just to give you an idea of what type of questions we asked, we talked a lot about barriers and facilitators to receiving SUD quality care. We talked about the differences in SUD received or offered through Medicaid fee-for-service in contrast to managed care, because we wanted to see whether there had been differences. And then what did they say about the evaluations of SUD quality of care? One thing that this authors really talk about, and I emphasize tremendously, is you want to make sure that the people doing the interviews are really people that are aware about the power imbalance when they approach, and how it's so important to make the person feel respected with a lot of dignity and recognition that they're the experts in what's happening to them, that they're not going to feel exploited by us in asking about all of this information. We really pilot tested the interview before we actually used it, making sure that the pacing and how we were structuring the questions was very conversational, and that we could build trust and rapport so people felt comfortable in disclosing a very sensitive topic. I have to say, private location and interviewer attitude is so important to make sure that you get the best possible information. And here we definitely had private rooms when we did the interviews in person. Or people, we make sure that they had a phone, that they were by themselves. We wanted to make sure that the interviews could last up to 60 minutes. And then we gave the participants $100 gift cards, but some of them could not take it, given that they were basically working for an insurer or something, and sometimes they felt they couldn't. We use this framework that you see here to generate the themes, which includes familiarizing with the data, making sure you create codes, creating transcripts, coding all the transcripts, generating and reviewing the finalized codes so that you could end up with particular themes. So we started, as you can see, with interviews transcribed or de-identified that were exported to the DOS. We met regularly to decide on what were the codes and develop the code book. We trained coders to make sure that if we have discrepancies, we could get consensus on how to deal with those discrepancies. We refine and finalize the code book with examples so it would be easy to do the coding. Then coders coded all the interviews, and we brought the discrepancies. 2 people coded every interview of the 40 interviews we had. We identified the themes, and then we met again to refine and clarify the themes. I want to say the main findings, which I found fascinating, were that clinicians really overall thought they had benefited from the transitions to managed care in certain aspects. For example, they were receiving more support and accountability in doing some of the, especially the administrative things they needed to do. But they felt that for patients, particular patients, and I'll describe which ones in particular, when having a lot of difficulty in navigating a system that kept changing and changed so frequently that it was hard to try to put more guidelines because it kept changing quite a lot. And certain things, for example, like quality of care, they felt really did not benefit for the provision of utilization management that had been done before. So, for example, one of the things we found is that the people that were likely to have inadequate care were the people with dual diagnosis. Those people that have both mental health and substance use were more likely to have more difficulty. Older adults, they tended to be less likely to receive quality care, and linguistic minorities. Overall, one of the things that came over and over again is that the types of quality indicators that the insurers were using were not really the ones they care for. I want to show you another study, a different one, and this is PhotoStory project. And we love this project because in a certain way, we really learned so much from the youth in trying to understand the social and dynamic context that they live, and how this context, was so important in explaining the escalating symptoms of mental health and substance use, how they saw themselves in the vision of what was happening in their neighborhood, but also how they generated how they could solve those problems, and how they saw the problem in a very different light than the way we had seen it. One of the things about Photovoice, it really gives you an opportunity for you to ask the person to really reflect and tell you about what really matters to them in terms of community interactions and concerns. It's also a great way of you having pictures to generate a dialogue for other people that might not understand the world of youth and how they experience these events in their neighborhood, and also for policymakers, because the youth then with these images could really advocate for what they wanted. One of the things is that we had done a previous work. This is why we decided to do this, the photo stories in this way, that, we had seen from another study, the Boricua study that we had done previously, how youth interactions of social support, social exclusion, and interpersonal relationships were so central in how youth felt about themselves. But these are things that are very difficult to capture, especially because you're talking about perceptions, you're talking attributions of social position, you're talking about social stratification and segregation that youth are confronting in their environment, in their schools, in the neighborhood. And then you're trying to bring this across, and then asking them to think, well, how would you work around them so this doesn't have an impact in your mental health? And there's so much history in the space people live and things that have happened, that trying to capture all of it in a way that's just not like a survey really requires more. So as I said, we use this very simple conceptual model for trying to identify where were the disparities that we were seeing in increased rates of mental health and substance use generated from. What were the experiences of social exclusion and discrimination, or experiences of social support and inclusion, and how did the youth, and this is where Photovoice is so great, can tell you about the cognitions, about behaviors, about how people are feeling those experiences. And from there, then you can understand where the depression, where the anxiety, substance use, or suicidality is generated. So here we went with 80 youth. All the project was 4 trainings that we did with the youth, 10 pictures each across 4 communities. We selected the 4 communities where the rates of mental health and substance abuse had been found to be going up. And then we wanted to examine differences based on minority majority status. So the youth were quite, were like youth from different ethnic racial groups. And we did the Photovoice in the first year and a half. We then, in the second year, presented the information to community forums and key informant interviews, where we talked to majors, we talked to people from the Chamber of Commerce, we talked to people that were in the state, involved in the state. And we also then, the last year and a half, we actually took 4 years to do this. We developed the intervention with youth. I want to say how I really think this is a great opportunity to merge 2 types of multi-level mixed methods research design. On the one hand, we wanted to use an intervention, a design that would help us, develop an understanding of what were the things youth prioritize and how did they see different layers of the problem. What were issues that were tied to themselves, but issues that were tied to the system, to the neighborhood, and what were the potential solutions that they thought about it. And then we also had a participatory social justice research design in the sense that we wanted to make sure that we were seeing the problems through the eyes of the youth, that it was the experience of the youth and that we were not driving how they were expressing their community. I want to say we also collected quite a bit of data from the Youth Risk Behavior Survey that had been administered in the schools. And that gave us quite a bit of information of what was happening, what were the things that we were seeing to present to the youth. And also it gave us an opportunity to also administer a very brief survey to the youth to collect their information. And at the end of the working with them for 4 years, they did an exit survey. This is just to show you what the youth said about their neighborhoods in terms of assets and challenges. And you can see here that some of the things were similar, but some of the things were quite different in how youth saw their neighborhoods. And what's important here is that they themselves generated, like, for example, East Boston, well, it's a history of an immigrant community. They had a lot of outdoor spaces. They had mentors and role models. In Charleston, they talk about spaces for recreation, good access to public transportation, and so forth. So they could generate information about their sites and had the pictures to convey this information to the audience. This is an example of the first training, and where they're discussing how do they see their community. And this is in Charlestown, where you can see one of the youth saying it's segregated a lot. It also goes back, the upper people only could live in places like Newtown and Michon, and African must live in the projects. And you can see here, they did boxes to identify where were the different groups meeting, and where did those sites were particular for one race or another. And then they said in Charleston, the projects and mission, there has been fights, like literally fights, just because they think they're better than the projects. And youth would talk very much about how they couldn't cross over from one street to the other because there could be a fight. This is a training 3 photo, and you can see here how now we're asking more about feeling and how whether they feel included or excluded in their community. And this is a youth that took a picture of, for example, a hotel, saying, I've noticed since they built this hotel, there's been more people. Everyone in Chelsea is like family. And just seeing someone you don't know and haven't seen before, it makes you feel weird. It's like 50-50 anger and confused. Why would they build a hotel in Chelsea? Why can't they use the money for something that would benefit the city? Chelsea is a mostly Hispanic and Latino community. And then once you implement a hotel, there are many more white Americans coming in. This is how we triangulated the information. You can see here, this is Charleston, the one that I presented before. And you can see how they use color, the different neighborhoods in Charleston, for which one the green was predominantly white, the blue was predominantly Black, the grayish was predominantly Asian, and so forth. And then you can see they took a picture from upstairs in the Bunker Hill Monument, showing the different sites, but then talking in the photo caption, it's the neighborhood, diverse, but it's not together. It's sad because I want a neighborhood where I know people and I feel comfortable with people. And then they took those comments of challenges to the forum, and then attendees at the community forum prioritize with different colored dots, which one were the most important, which were the red, which one was the second most important, which were the green, so that they could decide with which type of issue they wanted to work on and what was the potential solution. You know, having youth as a co-researcher is great because they also can tell you what would be acceptable for them and feasible for them. And this is where they said that a mental health intervention was not what would be acceptable to them. They really didn't want a mental health intervention. They wanted to really, from their perspective, concentrate on the problems, on the challenges that they were seeing in their neighborhoods that really affected them most. And through their eyes and through their thoughts and feelings, we could then understand what they wanted to focus on. I want to say this was pretty challenging project. There were issues about making sure that the youth knew how to follow the specific prompts for the photos. It takes a lot of time to coordinate youth to make sure that they have the resources and the time to do the work together. There are lots of issues in making sure that they finish the training assignments. Sometimes they forgot to take the pictures and they had to go back. Sometimes they didn't ask for a waiver to take photos of people's faces and get their permission. And sometimes we needed to make sure that they had phones or cameras for taking the pictures. In implementation, I have to say it was hard when the youth, bringing them back to all the meetings. Some youth actually worked, particularly the older youth, and some had longer commutes or child rearing responsibilities. So we needed to set what we were doing around their schedules. Overall, we were able to do this project on Photovoice with the youth as co-researchers, making the trainings and everything. And this actually was a great project in the sense that it took us to where the youth wanted to go, where they wanted to, from the get-go, make sure that we used it. And we ended up with what's called a LIP curriculum. It was an intervention that we co-developed with the youth. And this is an intervention where you're actually going to learn about your community, about interviewing people in the community, and then developing an action plan that you can do collectively with other people, learning about youth leadership, youth civic engagement and action, and the power of you communicating with people in power to address issues that affect you. And overall, we have a paper that if you wanted to read more about it, it's a paper that we did in community psychology, really presenting, you know, the project, how we generated the intervention with the youth. And now we're waiting to hear from NIH whether we're gonna be able to test it. They asked me, and I'm going to quickly just talk 2 minutes for this, but how to get funded this type of research. I think one of the most important things is making sure that you get philanthropy, especially at the beginning of the project. Places like the W.T. Grant Foundation, like the Spencer Foundation, like the Robert Wood Johnson Foundation are great places to get money to start the development of an intervention or to at least start developing the project that you want. If you have funding in your institution, for example, at our institution, we had seed funding, which is not a lot of money, but at least helps us in developing the concept so that we can then go to our R21 or an R34 to do the intervention. So I'm going to stop there, and I'm happy to answer questions.
Thank you so much, Margarita. It was a wonderful talk, and you covered a ton of ground. We do have a couple of questions. The first one is about the first study you talked about with your Medicaid data. And it sounds like you did a ton of work under that project. Can you talk a little bit about your team structure and the time and sort of manpower, person power that was involved in that project?
Yeah, so we were 6 people in the team. We had 2 economists, one person that was a programmer. We had a data analyst. We had, and then we had other clinicians. And then we had a big consultation team where we actually they didn't work all the time with us, but for different things when we were generating the performance indicators, they met with us to go in creating the algorithm. What really took an enormous amount of time was creating the algorithms and making sure that we were, for example, in medications, there are some medications that could be used for multiple conditions, not only substance use. So we needed to work with people that really knew about the different things that were used in medication and with which other populations could be used. So we make sure that when we were creating the algorithms, we were creating them in a way that was fair to the insurer companies. We also had people from codes, medical codes that we work with to make sure that the codes we were doing. And then we had great people from the Medicaid, the Office of Substance and Addictions at the New York State that worked the OASIS team. We actually presented the algorithms. We wanted to work with the state because, to be honest, this is for them, not for us. So we worked a lot with them, presenting them as we went to the algorithms. And when we were finding things, they would say, oh, you know, something's funny here, you should check this and that. So we worked quite intensively. It took, I would say, pretty much like 2.5 years to do the algorithms. And it took a long, long time to do the actual testing of the algorithms, another, I would say, 2 years. And so I would say overall, it took like close to 5 years to do everything.
Thank you. We also have a question. Dr. Perez-Folez said that this may have been answered, but I think being explicit about it for some of our other audience members, can you talk a little bit about how you approached co-creating things in your Photovoice study, and maybe some of the practices you used to keep those youth really centered in that process?
And I want to again say it was a team of people. Here we were, first of all, we were so lucky that we had a lot of youth that work with us, that were people, for example, talking to the youth, but working with us. For example, one of the things we had is that to co-create is to get like very intensive feedback for what you're doing, and saying, well, that's not going to work with us. For example, these icebreakers are not going to work because they're too boring. You need to do different icebreakers to add to the intervention. You're spending too much time getting feedback from us in surveys. How about if we sit down and tell you what's wrong, what's not going to work, and give us ideas? That's when they came to, this, no, we don't want a mental health intervention. It sounds like you're making us the victims, and we don't want that. We want to have people feel powerful about what we can do. And based on this, we can do quite a bit better. And they did a great job presenting, for example, to the forums. So they actually started showing, and they said how much they had liked talking to people in power. So based on that, we then went through iterations of potential things we could do. And they really liked this issue about civic engagement, civic action. You're mute.
Yeah. We have a similar question from Laura Vargas about how you manage some of the expectations when you're working, especially with youth in community, of the deliverables that you might have from an academic perspective, the outcomes you really have to prepare for, and then what community change or deliverables your youth or community partners really expect, and how you manage those two different expectations and perspectives.
Yeah, that's a great question. The questions are great. So a few things. I think, let me start by saying that in terms of expectations, we really were clear that this was a developing project. So we didn't have expectations for, in terms of like, you have to finish with a project, a complete project. When we were doing the LEAP project, we said something that you could do in a very short time period. So we actually constrained it by the time that people had. I have to say that nonetheless, some of the youth wanted big projects, big projects. And we said, that's actually not going to work, and you're going to be more frustrated than empowered. So we actually then try to convey, instead of doing like a whole campaign for lowering the rent, for example, of the rent in East Boston, let's talk about doing a video about why people should be lowering the rents and the importance of affordable housing. And so they created a video of that. And so it was more negotiating in the time frame that you have, what could be things that could be done. But I do want to emphasize that people should be careful. So because you don't want to harm youth by having themselves more higher expectations of what they can accomplish versus what they will be able to accomplish.
Thank you. If anyone else has questions, please feel free to put them in the chat. Let us know so we can share those. And I believe Jordan's put in the chat our evaluation. Please take a few minutes to fill that out as you leave today. I am curious a little bit about how, let's see, when you have gone out to work with youth, we've been doing some Photovoice projects here as well. How do you find the right youth who have the time, the ability to commit, and set the expectations for bringing them on board and making them a part of your team?
So let me emphasize two things, because this was work. So we paid for their time. So first of all, we really, the way we clarify expectations is we spent, when we went and talked to mostly youth organizations, is where we identified the youth. We offered them participating in this project as a paid job. And so for the hours they had, they would be paid $15 per hour. And if they participated, they were paid, they needed to come to work to get the funding. So that actually created sort of an expectation, this is a job. And second, I think the hardest piece is, making sure that you keep them motivated so that this is not boring, but actually interesting. They love the pieces where they interview, like the mayor, or they interview people in their work, in their neighborhood for finding out information, where they looked for literature about their neighborhood, what was literature, all of those things we told them in advance. And then we created groups that would work together. And that made it quite, I would say, more easy for them to stay engaged.
Great. This is similar, but more about your research teams. And your first project, especially, you brought up that you really have to have people conducting interviews who really understand the population and can create that open environment. Can you talk about how you develop and train that for interdisciplinary and culturally diverse teams, so that they're really providing that sort of linguistic, cultural, and meaningful experience for both your team members and your study participants?
Well, I think there's a combination of factors. We spend a lot of time on training people on engagement, on how to, really role play examples of engagement, of how you start an interview. We use, for example, telling them, a little bit about ourselves. We try to typically match people in terms of a lot of characteristics, if possible, so that they feel more comfortable. Sometimes it's not doable, but most of the people we had been doing a lot of the projects we do, which is with community health workers, where we train them on how to engage with people from the community in terms of, for example, how you pace yourself, how you use language that the person has used to describe the same phenomenon, how you try to put yourselves in, shared decision making, bringing them more information, but asking them, getting information. So it's making it more like a dialogue rather than an interview, only an interview. So we train them quite extensively, I would say, but the people were, I think they were very interested in also the types of questions we were asking, because we were asking their expert advice on what they had lived in the services and how we wanted to use this information to improve services. So making sure that you have a very good reason for asking them to participate, and how you are going to come back and bring the information to make sure that you capture it correctly.
Thank you so much. We are coming up to the end of the hour. I want to thank you for presenting today. And I want to thank everybody for participating and sharing some really great questions. Have a great afternoon.
And thank you so much, Sarah. And yeah, everyone, thank you so much for being here. I really appreciate it.
All right, thank you so much. And as you log off, please complete our evaluation so we can continue to provide really great seminars. Thank you so much.
Great.